on advanced care planning, goals of care, and healthcare consent in palliative care. We have two wonderful presenters with us here today, Tanya Burr and Sunil Rocci. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and original peoples in what we now know as Canada, and we are grateful to have the opportunity to be present in this territory. So some of you may know it, but I'll go into it briefly. The Palliative Care ECHO Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. We invite you to check out our website at echopalliative.com. And the ECHO Project is supported by a financial contribution from Health Canada. Therefore, the views expressed here do not necessarily represent the views of Health Canada. And thank you so much. I do see quite some movement in the chat, so thank you for introducing yourselves ahead of time. Briefly, some of you might know Pallium for our LEAP courseware and our LEAP products. Predominantly our most popular one, our LEAP core, is an interprofessional course that focuses on the essential competencies to provide a palliative care approach. It can be delivered online or in person, and it is accredited by the CFPC along with the Royal College. You can check out our website to find out more about any of our LEAPs and possibly register or for more information. Briefly, I'll go over the introduction. So my name is Diana Vince. I'm the Palliative Care ECHO Project Manager at Pallium, and I will briefly hand it over to our presenters to allow them to present themselves.
Thanks, Diana. My name is Tanya. It was formerly Burr, now McAdams. So I'm floating between those two names. So no worries if you knew me in my past name. I'm a nurse practitioner by trade, and I've worked kind of the gamut of retirement home, acute care, and home care, palliative. Currently, I'm in a leadership role managing transitional care for Bayshore in Eastern Ontario. And the topic today is certainly near and dear to my heart. So thank you for the opportunity.
Thank you. We'd love to have you. Go ahead, Sunil.
Thank you, Diana. Similar to Tanya, I've worked in a number of different facilities. First of all, my name is Sunil Rocci. So I'm an occupational therapist. Sorry? Oh, I'm an occupational therapist and a designated capacity assessor. Today, I'm speaking fully as a capacity assessor in this role, and I was trained by the Ministry of Attorney General's office, the Capacity Assessment Office, approximately 25 years ago. So I've been doing this kind of work for 25 years.
Fantastic. Welcome to both of you.
Thank you.
I'm briefly going to go over the conflict of interest. So Pallium Canada is a non-for-profit. As I mentioned before, we are partially funded through a contribution by Health Canada. And we also generate funds to support operations and research and development from course registration fees and the sale of our pocketbook. I myself, along with the presenters, do not have anything to disclose. I will briefly go over the welcome and reminders. So for the comments, please use the chat function and to introduce yourselves, which you have already begun doing. So that's fantastic. Let us know, from what province you're writing to us, your name, your profession. Thank you so much. And for questions, we'd like to encourage you to use the Q&A function that you may find at the bottom of your screen. The Q&A simply allows us to populate all the questions, and we will address the questions at the end of the session. So please also make sure not to disclose any personal health information during the session. The session is being recorded, and the recording and slide deck will be emailed to registrants within the next week or so. Well, without further wait, I will pass it along to Tanya.
I started off in great fashion being muted. So thank you everyone for having me and joining us today. Today's topic, I think we all manage day in and day out of our daily work. I really wanted to bring us back to the basics to get a really solid understanding of what advanced care planning is, what goals of care conversations are, but in particular, something that was very near and dear to the work that I did in long-term care as an attending is really that healthcare consent piece. And this in totality will really help and hopefully you can make it to the next session in which Sunil is going to be talking largely about capacity assessment and when to kind of reach out for capacity assessment. This is really the building block session prior to that. At the end, we're going to talk about some case studies as well, which hopefully will help hone in on these topics. And then likewise, we'll continue with some of these case studies in the next session. So what is advanced care planning? It's a process that involves the mentally capable patient. And that's the most important part for me. Advanced care planning is done with a mentally capable patient. Whether or not that capacity or that capability of that patient is in question. That's something that Sunil will talk to. But in most cases, if we're going to sit down and speak to a patient or one of our residents about advanced care planning, what their wishes will look like in the future, that patient has to be mentally capable to do so. So how is it done? And this is where really, within many different provinces, even I would, dare say many different regions, sometimes this changes and this is a bit different. So a person may communicate his or her wishes orally, in writing, by whatever means they use to communicate, and it's a voluntary process. So health facilities cannot require a patient to do advanced care planning, to use any particular forms, or to use a particular method for advanced care planning, i.e. levels of care forms. And this is particular, of course, to Ontario as I'm speaking, and hopefully we can have a bit more discussion about how this might look outside of Ontario. But ultimately, we cannot force our patients to do advanced care planning if they're not wanting to do so. So what are the important details to explore in advanced care planning? So one of the first pieces, whether you're in primary care, whether you are in hospital, whether you are working in the community, really we want to identify the future substitute decision maker and talk to that patient or that family about that substitute decision maker, who that is, what is their contact information. We want to confirm that their satisfaction with their default or automatic SDM, given that we know what that hierarchy looks like if somebody becomes incapable. Or they can choose someone to act as their SDM by preparing a power of attorney for personal care. And this is a formal written document that you would download off of the government website and then fill in accordingly. So 2 ways. You identify an SDM based on the hierarchy and ensure in advanced care planning that is who that person would like to make decisions on their behalf should they become incapable, or we prepare a power of attorney for personal care. Now, there are 2 types of power of attorney, one for personal care and one for finances. I'm not going to speak to the finances one in this session because Sunil will speak more closely to that in her session on capacity assessment. And the second piece of advanced care planning is really looking at sharing those wishes and values and beliefs. What is your patient value in life? Do they value, quantity over quality? Do they want to be alive with every measure possible because that is what they believe in most? These are parts of those discussions that you're going to have with your patients and residents in order to really understand what their decisions might be based on their wishes, values, and beliefs. And then you want to also ensure that the SDM is aware, or how is this patient making their substitute decision maker aware, and how can they clarify their values, wishes, and beliefs in a really general way, so that if they're cared for in the event of incapacity and they cannot give or refuse consent, that SDM can then make the appropriate choice based on what that patient's or resident's beliefs, values, and wishes are. So what is the quality of life that is important? Maybe perhaps you have a patient or a resident that only that reads endlessly. They are a literature hound, and all they want to do is read. And the lack or the inability of them to be able to do that anymore would be terrible. That would include a lot of suffering. So that could be then part of those conversations around what if someone would do in this particular situation. So who can take direction from advanced care plan? So advanced care planning wishes are a guide. And I really want to preface this and have everyone understand that they are in fact a guide. They are not laws to be, enacted in the event. They are a guide for the patient's SDM or power of attorney to make future or personal healthcare decisions on behalf of that incapable patient. So health practitioners must get informed consent from the patient or incapable patient's SDM or POA, even if the patient has done advanced care planning in any way, written, oral, or by alternative means. If a patient told me that they would not like antibiotics if they shall, become infected with pneumonia, I'm still going to talk to that patient if they're capable about their options for treatment and what that might look like. So even though they've documented that they wish for it not to happen, we still are obligated in Ontario as healthcare providers to ensure that we get informed consent. And what that consent might look like might vary differently. And again, we're going to talk to a little bit. Oh, thank you, Susan. Yes. Sorry, I'm in the chat. I'm just kind of watching things as well, too. Please point out anything that's a little bit missing, and I'm happy to change that after. So advanced care planning, ideally, it's not a one-time conversation. So as a practitioner, I can't sit down and say, checkbox, I've done my advanced care planning with, all of my patients. Wishes and values change over time. And as a person's health and their life status changes, perhaps they, what they thought was unmanageable 10, 15, even 6 months ago, so years and months, it could be vastly different when you have another conversation with somebody. So it's really important to have continued conversations about wishes in the event of incapacity, and then to document those wishes accordingly. And whether you help that patient document those wishes on a medical record, whether you help to document those in a way that makes sense for them in a paper form so that they can have those, whether you involve the SDM or the POA in those opportunities for conversations, and if your patient allows somebody to come and have a conversation with them, there are many ways in which you can share the values and wishes and beliefs and the choices that your patient may very well make. So an advanced care plan, a living will, or advanced directive, so these terms are not legally defined in Ontario law. And I think this is where things can get a little bit confusing for folks. It's heard in common language. A lot of these terms are interchangeable, almost you would say in common conversation. But a lot of these terms have been borrowed from other jurisdictions, from countries and other provinces. And the use of this can be quite confusing, or it can misrepresent healthcare consent or advanced care planning with an Ontario lens. So Ontario law requires healthcare practitioners, again, to obtain consent even when a patient has engaged in the process of advanced care planning or has documented wishes while they were capable. So again, that advanced care plan, it's a guide. We don't use the term living will or advanced directive. Yeah, great question, Brenda. Does this apply to Alberta? Is there any, I wouldn't know. I'm speaking a little Ontario-centric, understanding that this is a national conversation. And I'm really hoping to garner some conversation around, how healthcare consent is applied in other provinces. So if anyone has any comment to Brenda in the chat in regards to Alberta, that would be great. I don't have that exact answer right now, Brenda, but it's certainly something that I'm happy to take back, and at least we can kind of get those answers for you. So some resources I wanted to talk a little bit about. Now these, again, I've tried to keep these national versus Ontario-centric. There's some really great ACP resources for healthcare professionals and for patients. So they have the advancedcareplanning.ca, which is a really great website that I would send patients to as well. It has booklets that can be downloaded, great little conversation starters, some videos. And it really introduces the idea of advanced care planning, allows patients and families advise whomever to actually have a look at this website and have an understanding of what they're undertaking when they have these conversations. First Nations also has a Healthy Living Advanced Care Planning website that I found quite interesting. Please have a look at that. Perhaps send those applicable to that website. I think it just might be a little bit more mindful of what First Nations advanced care planning and how it might differ. Healthcare professionals, so the LTC toolkit from the RNAO, again, this one's a little more Ontario-centric, but they have a really great toolkit for advanced care planning in long-term care specifically, which can be something that your team can use, as well as a couple of other little ones in there just to have a look at. I would offer a lot of resources for advanced care planning. It's quite a big ticket topic and lots of people are creating documents, but these are some of the more common ones and the ones that have been a little bit more vetted through use. Okay, so what are goals of care conversations? We know what advanced care planning is. So what is a goal of care conversation? So goals of care conversations are focused on the context of a current illness. And this is where you get that difference between advanced care planning. So advanced care planning is looking future forward, what could possibly happen, what are my values, my beliefs, my wishes, and what would I want to happen in case of X. A goal of care conversation is focused on the context of the current illness or X. And that's in relation to the expressed values and wishes. And this leads to a treatment choice or a decision. So for example, an 89-year-old male patient of a long-term care home has expressed wishes prior to his incapability that he did not want to be transferred to the hospital in the event of any illness. It's a pretty common pretty common advanced care planning conversation. And likewise, a pretty common undertaking for no transfer to hospital in the long-term care setting. He requested that he be provided comfort measures only. During his time at the LTCH, he was diagnosed with pneumonia and began to show signs and symptoms of sepsis. Goals of care conversation was held with the SDM, and a treatment plan was created to support the expressed wishes of that patient. So a goal of care conversation, again, I believe you can, Brenda, get copies of PowerPoints. The goals of care conversations, again, are focused on a specific illness leading to a particular treatment. Again, based on values and wishes. That goal of care conversation can take place with a competent patient or a capable patient, as well as with a incapable patient, the SDM or the POA. And again, this is the differing factor for ACP can only be done with a capable patient, but a goal of care conversation can be done with a capable patient and can be done with an SDM or a POA. Any questions about that one? I find this one is a bit, it can be a bit tricky, but ultimately it's not even the consent hasn't even happened yet. This is the conversation leading towards that treatment, if that makes sense. So what are goals of care conversations, and when should they happen and how should they happen? So these conversations should happen in a private and a comfortable space. And therefore, sometimes they need to be scheduled in advance. Now, I understand that this can't happen all the time. Sometimes goals of care conversations happen on the fly. A new issue is made note of and it's rather urgent and we have to have those conversations. But ultimately, some of these goals of care conversations can happen in a private and a comfortable space. They could be booked, even an hour or two out. It's really to ensure that the person you're having these conversations with is in the space and the headspace to make an appropriate decision should one be required. So you want to prepare, you want to become an expert where that patient in the clinical context is concerned. If I'm going to talk to a patient about, needing to go to the hospital in relation to their COPD exacerbation, I should really understand COPD, the exacerbation and the history of that patient so that I can make sense of what this conversation should look like. You won't want to confirm the patient's preferences when it comes to including family or friends in the conversation. If the patient is capable and they don't want to include their family or friends in their decision or in the conversation, they do not have to. I find this is particularly a difficult a difficult area in long-term care or in dealing with, our senior population. Many times, there's this blanket kind of overarching idea that there's this incapability in this patient. It is really the obligation of the healthcare provider to ensure that we're having a conversation with the patient to ensure that they can make that decision themselves and have the right to do that. If the patient is capable, you want to explore if they have an SDM. And if the patient is not comfortable with their automatic SDM, again, you want to you want to talk to them about that power of attorney document. If the patient is incapable, the conversation has to happen with the SDM or the POA if there's one there. So again, same conversation, except it can be had with two different groups of people. And the onus of the obligation is on the healthcare provider, the person who's going to order that diagnostic test, provide that treatment, to ensure that that patient has consented for that treatment and that conversation's had place. So healthcare consent, this is the big one. So the other two elements, are really important to understand how we get to the point of healthcare consent and what we're doing up until that point. But this is the one that I saw the biggest, I had the most concerns with in and out of long-term care, kind of managing seniors in that palliative patient population, is the idea of healthcare consent. So nothing about me without me. And there's actually a really interesting, national product on nothing about me without me, if you have a look on it. And it's a lot about, planning these services and ensuring that people have consent, and we have consent as medical providers to ensure patients understand what their options are. So healthcare consent for treatment, and this is straight from Ontario law. So I'd be interested to hear from other provinces if that's the case. There is no treatment without consent, and that is the flat out from Ontario law. So if you have not received consent for a treatment, either from the patient who's capable or from an SDM or a POA, if that patient is incapable, then you've missed that and you are obligated to do so. So it's of the opinion that the person is capable with respect to the treatment and the person has given consent, or a health practitioner who proposes a treatment for a person shall not administer the treatment and shall take reasonable steps to ensure that it is not administered unless, and those two options are there. They're capable, or they are of the opinion that the person is incapable and the SDM or the POA has given choice. This was really a really difficult, I want to say, topic or conversation within the walls of my healthcare long-term care home. Many times, nurses, our allied team in general, or healthcare team, we would automatically talk to the families, the SDMs, the daughters, the sons. And many times the patient themselves were missing in this conversation. Many times family or patients would come to me. It could have been even the nursing staff asking for a urine dip or asking for blood work. And I would, ask them, who have you spoken to? I spoke to the daughter and they want blood work done. Have you spoken to the patient? And there's this kind of idea that these patients are incapable. They're unable to make these choices. And whether or not they have a diagnosis of dementia, as Sunil will talk to, that is less important than the understanding, the appreciating of knowing what they are asking or what we're asking for. So I thought what I could do maybe perhaps is take a couple of questions about some of the things, if there are any, we just spoke about, and then we could have some larger conversation about the next two case studies. I did see that Celeste wrote in there. Yeah, so great point, Celeste. I agree with you. Goals of care conversations. are best had in the context of chronic illness that pose a risk to the person's future health. These conversations are best when not in crisis, when there is a sudden change in condition that is typically when a consent for treatment needs to take place. Absolutely agree. You'll find that I think, in all cases, you can have plenty of conversations or goals of care conversations about chronic illness. And you will find that if you spend some time having conversations and advanced care planning about that your urgent goals of care conversations might not be as daunting. I also think that you'll find, or that I found over time, that I've started to really, you start to understand the nuances of those conversations a little bit more, and you start to dig into perhaps some of the past history that that family might have in relation to some of the reasons they're saying yes or no to those. So I thought I could, are there any questions about healthcare consent, or, I guess any concerns from your province that you might have? If not, I'll kind of move into the case study and we can kind of just open that up for conversation. So Mrs. Bronson is an 85-year-old who lives on her own. She's a widow of 5 years. Up until this point, she has managed independently with some support from her daughter, who lives about 50 miles away. So I said miles, kilometers, we can toss that in there, it'll be about double that. And her neighbors. A recent fall has resulted in a marked reduction in Mary's mobility, and currently she's requiring support with her IADLs, so her instrumental activities of daily living, shopping, cooking, and some personal care needs as well. Mary has been assessed by a physiotherapist who feels that the best option would be for her to move to a nursing home. And I think we've all been in this particular spot before, when we've been brought in for consult, saying that somebody is failing at home. So her daughter supports this recommendation as she feels she's not able to offer her mother the support she needs and worries about the new onset confusion. Mary has stated that she does not want to go into a nursing home. What do people think of this case study? Are these similar things, if you've worked in the community, you might have heard before? What have you found, or what should we be looking for in the sense of advanced care planning, healthcare consent, goals of care conversations? How would you approach Mary? And just a note, Diana did note that participants cannot speak unless you put your hand up. So if anyone would like to chime in, that's great. Explore fears. Perfect, Sheila. Exactly. Yeah. And I think duly, it's probably fears on both sides. What are the daughter's fears about the situation? What are Mary's fears about the situation? I would certainly want to know more, further assessments. Why the confusion? Perfect. Great, Ruth. Yeah. So why is is there an infectious reason for this confusion? What type of, clinical workups might be needed to do so? Supports available. Exactly, Elizabeth. What does she currently have in the home? Why are we jumping straight to nursing home? And this case study I've done purposely. You'll find if you do a lot more community work, there's this often jump, and I don't have the data to support this, so this is a bit more of a personalized type of viewpoint. But I do see a lot of jumping straight from the this is where we're at, straight to nursing home or straight to here, versus kind of understanding what's happening in the environment and what's available first. Yeah, as Angelique said, very typical. Hard when this conversation was not brought up before. Perfect. So these are daunting conversations. You would want to know her medical history, as Ruth pointed out earlier, why the confusion, what happened, what happened with this fall that that made her her marked reduction in mobility. What services does she have currently in her home? Those are the type of things you're going to want to really kind of build together to understand this case a bit more. Is there an underlying delirium? Exactly, exploring capacity assessment and going from there. Some of these case studies will be very helpful in the next session, because we'll move these over and explore them with a little bit of a different lens. So what ultimately happened to Mary in this? So what are we going to consider? So clinical concerns, her needs, her social supports, her housing and living situations, her IADL and ADL needs. Lots of those are mentioned in the chat. Perhaps who else should we be involved? We know that we can't be everything to everybody all the time. And whether, your role is as a nurse in the home, allied health, whatever your role might be, you might not be the right person for this patient at this time. So social work, do they have a primary care MRP? Am I that primary care MRP? Do they have a physician? Is the daughter the only SDM? Is there a POA? There's so many questions, I think, to ask within this case study that you would really have to sort out before you could decide whether or not Mary required nursing home level care and or wanted nursing home level care. And that's kind of what I was getting at in this is, although she might have had this element of a new onset confusion, and we don't know how often it's happening, ultimately, at this time, Mary has not been deemed incapable, or it wasn't stated there. So what does Mary want to do? So Angelique's also pointing out, so as Sunil will probably bring up, the financial situation will need to be discussed. 100%. Thanks for bringing that up, Angelique. I think a lot of us sometimes as, medical providers are a little uncomfortable speaking about finances and financial situations, but financial situations can change the landscape totally for patients. It could change where they're able to live, what they're able to afford. And likewise, as many of you know that work within the long-term care sector, one person or one spouse moving into long-term care can affect the other spouse significantly, and if they can afford to stay where they are. So lots of conversations, I think, about finances need to be discussed. Lots of people, you're right, don't understand the cost of private care and what the public system is prepared to offer. And I think that's interesting, Angelique, that the CLSC budget is revisited every month. So the care might not be constant as well. So Angelique made a great in the Q&A as well too. I'm keeping an eye on this as well because it's all kind of interplaying into our case study. Thanks, Angelique, on that. It's important to remember when family members are in different provinces. Not something that I've had to deal with personally, but a really important piece to reflect on, especially if you're talking about advanced care planning and any of those documents, understanding that family members in another province might have a different understanding of the laws and regulations in that province versus the one where their family member is. So thank you very much for that. Crystal mentioned in regards to younger patients with chronic disease, when did they start having goals of care conversations? Crystal, I started pretty much right away. To be honest, when I was working in primary care, I would have conversations with patients with chronic illnesses at the moment of diagnosis to let them know what prognosis might look like. That's a big piece. Not to mention, what they might find along the way, how their illness might change, how it might affect them. And if you start having that conversation on, the very beginning, I think it's certainly a bit more fulsome as you get going and as you have those continued conversation as that illness or chronic condition changes. So if we've gathered all this piece here for the case study, and we know we have an idea of what the other elements of Mary's case might be, in the end, we found out that other professionals, we involved primary care, nursing, and social work. The confusion, as mentioned by Ruth earlier, a clinical workup was done, including a urine for CNS and standard laboratory testing. Mary was diagnosed with a UTI, and upon further review of her cognition after treatment, Mary was reported to have not to have any signs of ongoing confusion. So there's that really important piece of understanding that somebody also needs to be medically stable in order to have these conversations and really be offered the opportunity to make the appropriate decision. Mary's daughter was involved in the conversations and planning. However, given her mother had capacity, she could not dictate the circumstances of her mother's living arrangements. This is really tough for us as providers sometimes, to be stuck in the middle of family dynamics, particularly one that I'm seeing more and more, which is that seniors in our communities are wanting to stay at home regardless of the risks, and many children want them to go to an area where they'll be safer. I would imagine that these will be conversations many of us will have over and over again in years ahead. So Mary, importantly, she understood and appreciated the choice and risk to live and remain at home. And the terminology of that understood and appreciated, that is really important verbiage for when Sunil will talk to you about capacity assessment, in the sense of, do your patients or the person that perhaps Sunil is doing her capacity assessment with, do they understand and appreciate the choice and the risk? So leaving that there as a bit of a preface for the next session, but that's really helped me as I navigate many of these common situations in my new world, in the transitional care world, is that idea of understanding and appreciating. So I have another little case study just to chat about as well too. So Mr. Kavanaugh is a 73-year-old gentleman who lives in long-term care. His medical history is moderate cognitive impairment, COPD. He's had a history of a CVA. He has AFib. He has a 3.5 centimeter AAA and hypertension. Pretty common medical history for the folks that we're starting to see in long-term care and have been seeing for a long time. In ADL is an assistance of 1 with dressing, eating, and toileting. Mobility, a 2-wheeled walker with 1 assist. He is the DNR, and his daughter is Angela, who is his power of attorney. At 3 a.m. on a night shift, Mr. Kavanaugh's nurse notices that he has become febrile. On further examination, she discovers his heart rate is 124 beats a minute. It's irregular. His O2 sats are 88% on room air. His respirations, he has crackles and decreased breath sounds at the right, middle, and lower lobes. The nurse notes that Mr. Kavanaugh is not answering her questions appropriately and appears confused. What would you do in this situation if you were this nurse? How best to ensure that you're meeting your obligations of, not only goals of care conversations, but of healthcare consent? All right, it's a little quiet, so I'll chime in and maybe get everyone to try to, so if you were the nurse, oh, there we go, follow up with the daughter as the client has a DNR. It does not indicate what interventions the family would like. Perfect, great. So we know that he's confused and he's not answering. The nurse has tried her best to have a conversation with the patient, and he is not at that time. He doesn't appear capable because he's unable to communicate. So exactly that. They should reach out to family to know his goals of care. Where per se in a long-term care home might you find what the goals of care might be for Mr. Kavanaugh? Is there a place in your long-term care homes? Do you keep them in your care plans directly in your care plan? Perfect. So having a look at that care plan and making sure, what are the goals of care? Have they had a conversation? Is there anything in the clinical notes? Sheila writes, explaining the risks and benefits of both an acute care setting assessment and treatment and what long-term care can offer. Thanks for mentioning that, Sheila. I spent a lot of time in long-term care having this conversation. This is what will happen likely if your loved one goes to the emergency room for assessment. This is what we can offer in long-term care. And then really having that conversation around what were the goals and values and wishes and beliefs of that patient or resident, and which one of those options would best suit that. Yeah, is there an advanced care plan, Mary? Right, we have no idea. Mr. Kavanaugh could have come into the home and he could have been here for 3 days, and we might not have any of these elements documented, and maybe perhaps those conversations haven't had. So we know that his POA is his daughter Angela. So we're going to call Angela and we're going to coach Angela through what the options are for Mr. Kavanaugh and really what we think as clinical providers, clinicians, what the prognosis might be and what the outcomes might be. If the nurse has any worries or questions on the unit, what should they do next? Do you think they should reach out to the MRP, the on-call? Should they do that right away? Should they do that in the morning? Is there certain ways in which your home would rather have things done? Yeah, so Elizabeth, great. Call the on-call right away to see if he's, unstable. Perfect. I think that's always the best way to go. I often hear or when I was working more long-term care, sometimes some of my residents were transferred in the middle of the night, similar to this. And likewise, I think if I had received a call ahead of time, I could have probably had a bit of a different conversation with the staff, perhaps, the family, just to kind of align better if there was an ACP or goals of care conversation that mentioned not wanting transfer. Yeah, and appropriate management of symptoms as well as per client wishes. So there's lots of medical pieces, but you can see the very different, how easy it is to perhaps, as in the first case, just move forward without all of the pieces of information. And in the second case study, although we're getting to the end quickly here for questions, but the second case study, if we had gone back here, and instead of Mr. Kavanaugh being incapable, Mr. Kavanaugh was capable, and he could answer the question. And he decided that he did not wish to be transferred to the hospital, and he wanted to stay at home with comfort measures. But his family, were notified of this, and they wanted him sent. What would you do then? And I know that's not in the case study, but this is often what happens, I find, in long-term care. A family member would like to override that choice. Perfect, Roy, and exactly, support and educate the family. So it's really important that classic scenario, says Elizabeth. Yeah, it's one that I ran into probably at least a few times a week. It's important. If anyone takes anything home, I think today from this, is that putting yourself in the position of the patient can really be helpful. If I was a very capable patient and I had a decision to make about a treatment that was offered to me, I would want to be able to make that choice. Having that decision taken from me and allowing somebody else to make it, that's what that SDM and POA is. We are taking that decision from a patient or a person and allowing somebody else to make it for them. So at the base level, it's really important just to understand that even a small decision can feel like a big one when it's something that you can't make yourself. And that many of these choices are also invasive. They're time hefty. So take the time to ensure that your patient, if they can, has the opportunity to make that decision, because it's an obligation that we have as providers. And it becomes really difficult, Royanna is saying in here, when we know their goals and wishes and then they lose capacity. It's really difficult, especially when sometimes we spend a lot of time with these patients in comparison to even some of their SDMs or POAs who might live out of region and not see them as often. And I think that's where that advocation really on our end is important. But also when things become really hefty and difficult, do you have an ethics committee that you can work with? Can you pull in other people to help you through this? And then obviously Sunil can help a little bit with how, some of this capacity piece and, supporting families can really help. I've also seen some patients, end up with PG&T because of their, unlikely ability to get a good SDM in place or a POA for themselves. It's important to have a conversation alone, Angelique says, and I agree. I had many, I would offer if family wanted to join, but I would usually have that conversation alone, and then either invite the family to have a conversation together as a group, or if the patient wanted me to deliver that message for them, I would. But there are many times in which our families can be very strong in their opinions. And I think sometimes our patients are a little bit easy to just say, do whatever my family says. I don't want to cause any difficulty. What about cultures that have relational decision-making? So difficult, Misha. ultimately our law, in Ontario is our law. So, we as practitioners cannot move forward without consent. You may have that consent, but I think it's very important to get consent from that capable patient. They have to say yes. They may say yes, and it might feel like it's under duress a little bit, perhaps, or no for that matter, from family. I think that's the important piece, to make sure that you're bringing in your leadership team with you, talking to your, your colleagues, whoever that might be, and bringing in ethics if you have to, in order to advocate or support for that patient. But those cultural pieces can be really hard to navigate. Ultimately, the onus is still on the provider to ensure that they have consent for that treatment. And then John wrote, talk to patient. They're supposed to follow patient. Yes, agreed. It's really difficult, John, to kind of have a conversation even 5 years prior, and then your family member might say, I never want to go to the hospital. I don't want any treatment. I just want to be comfortable. It's very difficult, though, as a loved one to just oblige that, if the conversation hasn't been more recent. Because, ultimately, when they're making that decision, they really have to live with that decision. And I think sometimes the emotions of that get really difficult. I would argue that this is also not work you should have to do by yourself. This is really hefty emotional work. It's also time heavy. It can be a bit administratively heavy as well, if you're documenting and having these meetings and documenting those meetings. But it's not something you should do alone. And if you're, perhaps worried about the conversation, if you have some concerns about the capability of your patient, or for that matter, the choices that family are making, I think it's really important to then bring in some colleagues or some peers to help sort that out and can continue that conversation. It is exactly that, Angelique. So many conversations day in, day out. I would imagine if I was diagnosed with, let's say, COPD in my 50s, and I was managing well up until kind of, my 60s. And then let's even say I got progressively worse by 65. My conversations about advanced care planning, and it would be vastly different in that 15-year time span. What I would tolerate, perhaps, what I wouldn't tolerate, in year 5, I might tolerate in year 15, is what I'm getting at. That understanding that as your illness changes, what somebody is willing to manage, what somebody is willing to entertain, what their beliefs and values, those are going to change over time with the illness. So we have to keep rechecking in. And John gave a really great comment. Try to remember that emotions take time to process, and patients and families need time to process. And this goes really well back to the comment from, I believe it was, sorry, I can't find exactly who it was, but you have these goals of care conversations, and you have those earlier on. You'll find that the emotions and the processing are still there, but you're not having to have these crisis goals of care conversations about something you've never even spoken about, i.e. an end-stage COPD conversation, when no one's had, this is what COPD is from the very beginning conversation. Yeah, Angelique writes, consider choosing younger or a 4-year POA if you are of advanced age. Another 80-year-old might be. Yeah, I see this a lot. Sunil, I don't know if you see some of this, but POAs and such, and SDMs, people are, enacting those, and their POAs and those SDMs might be of, kind of elder age as well. So there's concerns about their own health as their SDMs away.
I see the 2 main issues that I see. That's one where they're also maybe not quite the right choice at this point, because they're also aging, and maybe not in the best position to make decisions on behalf of someone else, even if it is their loved one and they know what they would have wanted. The other thing I often see is someone's in England or another country, and practically speaking, they can't really be that active in making decisions on that person's behalf, like such as paying bills and things, because 90% of my assessments have to do with property, which is financial decisions. So I see that practicality out the window, and we always try to say, is there someone local who can be the person who makes decisions on their behalf.
Thanks, Sunil. And I likewise, I see this a lot, even if you're trying to contact a POA or an SDM off of someone's file. I think this is probably across the board, acute care, retirement, community. The contact information can be a bit difficult, especially like you said, if we're trying to deal with people in different time zones and provinces that aren't able to be on site. So super important to choose the right person. And Sunil's going to have a bit more of a conversation about, again, perhaps the POA element and in her talk, power of attorney from a financial perspective. Again, it's a little different and a little, and definitely requires some further understanding. Ruth writes, it's also very challenging as dementia progresses. Yeah, this is a really big one. And I would like to argue and toss out that, again, dementia is not a blanket diagnosis for incapability. Somebody might be incapable, with their dementia to perhaps be able to call a taxi, go downtown, go shopping, complete those executive functions of things. However, they may be very capable that they can appreciate, understand that they have a urinary tract infection and they would like antibiotic treatment. So I think it's often that too, that balancing of, what is somebody capable of deciding versus what they are not capable of deciding. And I think that those nuanced conversations become easier with time. But definitely, if that gray zone exists, it's always helpful to have a different colleague come in and maybe do an assessment or have that conversation to see if you both landed in the same area of capability. Sunil, I saw you kind of had a bit of a comment there.
I was going to say, I'm noticing someone asking a question about POAs, and I'm also noticing the time. And I think it's only, we have an hour, and there's, I'm kind of wondering where to go with my presentation. But I'm thinking, since we're really talking about power of attorney, the most important thing that I would want everyone to consider and realize is that even if someone now steps in, let's say we're at the point of incapacity and an assessor like myself has come in and deemed them incapable, and now we're going to invoke that POA. And so here is the person who's now the POA. They are not the boss. They are still not the boss of that person. And that's what people don't get. It's still a collaborative approach. And let's say there's involved other family members who have not been appointed as an attorney for property or personal care decisions. They should be consulted and brought into the conversation. Unless that person, when they were capable, said, please don't involve that one estranged child of mine. We're not even on speaking terms. I don't want them part of the process. So I'm not here to obviously talk about legal, like I'm not a lawyer, so I can't give legal advice, but in my experience, I know a lot about this. We're almost pseudo lawyers by now, where we kind of know how some of it works. So sorry, go ahead, Diana. You want to say something?
Yeah, sorry, the Q&A at the bottom, the website for appropriate POA. So Sheila, they're provincial. There is a Ontario provincial one in the government website that has 2 documents that you can download. It does, speak to all the requirements about who can be a witness and, who can actually sign on that POA. There's 2 of them, one for personal care and one for property. So we can certainly get you those links as well.
Yeah.
And I did answer those earlier, Diane, I think, when we were.
I just wanted to confirm that you did. We did have one comment in the chat regarding from Angelique. I don't know if you got a chance to see that, Tanya. It was during your presentation that in Quebec it is important to have a paper copy. Did you see that one? I'll just read it out loud.
Oh, yeah, read it. Yeah, if you wouldn't. Sorry,
Yeah,
I think I might have missed it.
Sure, of course. So in Quebec, it is important to have a paper copy of all documents, to never presume, especially in an emergency situation, arriving by ambulance to the hospital, that the doctor has access to the important documents. It also helps when there are many family members with opinions of care to be provided. So
I love this, and I cannot agree more. I understand it's really, it can be a bit tough to have like documents with you all the time, like dependent how thick they are. I would argue that, your so if you have a way to ensure that they are stored in a particular spot, that the SDM and the POAs would know where to find those. And many times I've had many patients bring them on site to LTC. We've made a photocopy of them. We put them in the chart in primary care. Likewise, we've scanned them into the EMR, so they're part of that as well. So on your end, you can ensure that they're stored in a very safe way. From a personal standpoint, it certainly makes sense to, if there is something small that you can maybe have in your wallet or whatever that might be for transfer. But I would agree, you cannot assume that anyone where you're going will know what your wishes are.
fantastic. Thank you so much, Tanya and Sunil. This was so informative.
You're very welcome.
Thank you so much, everyone, for attending today and for joining us, of course, as always. We have included a feedback survey following the session. It is in the chat. We always want to hear what you're saying. And yeah, we look forward to seeing all of you at our next ECHO session. Please check out our website to stay tuned. Thank you so much, everyone.
Thanks for having me. Thank you, everybody. Take care.